Induction of labor. A definition is artificial termination of pregnancy by inducing labor. An indication of induction of labor. Whenever continuing pregnancy will harm the mother or the fetus. Example, post-term pregnancy, premature rupture of membranes, chorioamnionitis, medical disorder. Example, diabetes mellitus, hypertensive disorder, chronic nephritis or acute renal failure, jaundice with fetal distress, congenital fetal malformation, intrauterine growth restriction, intrauterine fetal death. Antepartum hemorrhage not suitable for conservative treatment. Factors affecting success of induction. Bishop score. The Bishop score takes accounts of the cervical length, cervical dilatation, cervical consistency, cervical position, and the station of the fetal head. A score of 9 or more is favorable for labor induction. See the table. Dilatation take 0 when closed, 1 score when 1 to 2 cm, 2 score when there is 3 to 4 cm, and 3 score when the dilatation is 5 cm. Effacement up to 30% it takes 0. From 40 to 50% it takes 1. From 60 to 70% it takes 2. More than 80% take 3 scores. Consistency either firm, medium, or soft. Position of the cervix, posterior, middle, anterior. Station, -3 takes 0. -2 to -1 take 1. -1 to 0 take 2. +1 and +2 take 3. Parity easier in multigravida than primigravida. Age easier in young age than elderly. Fetal maturity, gestational age. The more mature, the better result due to higher estrogen level. Methods of induction, artificial rupture of membrane plus syntesinone are better than any one alone, and prostaglandin are better than syntesinone. Methods of induction of labor. Preterm delivery with all complications of prematurity. Cervical ripening by prostaglandin. Prostaglandins are effective in inducing cervical ripening, softening of cervical collagen fibers, which effectively results in success of labor induction. Prostaglandin E2, dinoprostone, vaginal tab or gel. Prostaglandin E1, misoprostol 25 microgram, vaginal tablet inserted into the posterior fornix. Repeated small doses of misoprostol to 25 to 50 microgram can be used to induce uterine contraction. Amniotomy. It is an artificial rupture of membranes. This is done to initiate or augment labor or to allow fetal skull blood pH assay. The cervix must be at least 2 cm dilated to allow safely performing amniotomy. So, artificial rupture of membrane should not be used when the cervix dilated less than 2 cm. Amniotomy appears to release local secretion of endogenous prostaglandin. It is done by passing a special hook along the finger or by direct fission using speculum to rupture the membranes overlying the presenting part, but care must be taken not to damage cervical or fetal tissues. The color and the quantity of the liquor removed should be noted. Labor may not become established after amniotomy alone, and it is usual to stimulate the uterus further by IV oxytocin if contractions are inadequate. This is the amniotomy. not rupture of membrane by hook. Complication of amniotomy. Placental separation, abruption, may be caused by sudden reduction in intrauterine pressure, especially in polyhydramnios. Vaginal bleeding, soft tissue, and fetal injury should be excluded. Prolapse of the cord, especially in ill-fitting presenting part. Fetal heart rate monitor is a must after amniotomy. Infection. Intra-amniotic infection may occur if the interval from amniotomy to delivery is excessive and both mother and child are at risk. Careful antiseptic techniques and prophylactic antibiotics are strongly recommended whenever delay is anticipated. IV oxytocin drips. Synthetic oxytocin by continuous IV drips is commonly used after amniotomy to stimulate uterine contraction. Doses should be carefully titrated and monitored as the drug is powerful and uterine response to stimulation is generally unpredictable. That means it might be strong enough to cause rupture of uterus. IV oxytocin is best administered by suitable semi-automated infusion system incorporating an accurate drop counter. Other methods: stripping of membrane, separating of the membrane from the decidua, breast massage to stimulate oxytocin release, a sponge tent in the cervix or laminaria tent. These are wood tool used or inserted in the cervix that absorb water and so dilated the cervix. Tampons in the cervix also may be used in induction. Complications: failed induction, there is increased cesarean section rate. Iatrogenic prematurity if gestational age was not assessed accurately. Complication of each methods used: amniotomy, prostaglandin, syntesinone. Contraindication for induction of labor. Maternal, any contraindication for vaginal delivery, such as contracted pelvis. Any condition that make normal labor dangerous for the fetus or the mother. The commonest one is prior uterine surgery. Hypersensitivity to the drugs used in induction. Complete transaction of the uterus, myomectomy, reconstruction. Over distension of the uterus, such as polyhydramnios, twins, macrosomia. Fetoplacental contraindication, preterm fetus without lung maturity, accurate fetal distress, abnormal presentation.